Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about uteroplacental insufficiency and its management. Right? So, meaning thereby that the baby and remains in a uterus, and there is an sort of an the adaptation from the uterus with the demand from the fetus. So, as we know that the pregnancy can be divided into three trimesters, first, second, and third. So, as the baby grows, which grows exponentially, and therefore the demand grows from the baby to the mother also grows exponentially, and that gets reflected into the blood flow. Most of the cases, in 90-95% of the cases, what happens is there is usually an adaptations of the uterine arteries and then the umbilical, and so as to ensure that adequate amount of nutrition and the blood flow is available to the fetus for its own development, for the development of the baby in the second trimester and the third trimester, and so on and so forth, right? But we can have an early onset uteroplacental insufficiency, and we can have a late onset uteroplacental insufficiency. We are more worried about the early onset because then we are grappling up all these issues at something around 28 weeks onwards. And so the baby is having low birth weight. We are dealing with the prematurity. How do we handle all these things across? And then if we take the baby out, then probably we are dealing with the prematurity and ICU admissions and all those stuff, right? So today we would see two cases, and then we'll discuss how our management changed the scenario, right? So मैं आपको दो केसेस आज दिखा देता हूँ, जिससे मैं ये कोशिश करता हूँ आपको बताने की मतलब हाउ डू वी हैंडल दीज डिफिकल्ट केसेस, राइट? तो ये फर्स्ट केस है, इसको बहुत ध्यान से देखिए। तो ये यूट्राइन आर्टरीज की आरआई है, विच वी आर आइडेंटिफाइंग कि बाइलेटरल है, इट वाज ग्रेटर देन 95 परसेंटाइल। ये रेजिस्टेंस इंडेक्स है, ये भी 95 परसेंटाइल से ऊपर है। सो एज एक्सपेक्टेड अम्बिलिकल आर्टरी की जो पीआई है वो भी 95 परसेंटाइल को टच कर रही है, एंड दिस इज द अम्बिलिकल आर्टरी आरआई, सो दिस इज एट 95 percentile. And as expected, the amniotic fluid successively is decreasing down, right? So now how it is manifesting is this, that we are having a growth stagnation. So this is biparietal diameter. Similarly, we are seeing the head circumference. This would get astonishingly reflected into this abdominal circumference. So we can see an S-shaped curve, right? Long bones में बहुत ज़्यादा फर्क नहीं पड़ता है, right? And this is the femur and was the humerus, and this is the fetal weight expected. So we are seeing this growth stagnation. So we eventually had to deliver the baby at 1.4 kgs. This is the second case. So ये देखिए कि हमने इसमें as the pregnancy was advancing, the uterine arteries they have fallen, right? And since this is the umbilical artery PI, so this is also has gone down, and the resistance index has also fallen, right? And similarly what we can see that there is an uptick in the growth. So this is the biparietal diameter, head circumference, and abdominal circumference में अगर इसको ध्यान से देखें तो we'll identify that there is an uptick of the growth of the baby within a span of 10 days. So this is a catch up growth. This is the femur, long bones, and this would be the humerus, and this would get reflected into the effective fetal weight. That will also identify that there is an uptick, right? Uteroplacental insufficiency can happen because of number of reasons. Mostly they are thrombophilias. We can have 7 to 8 varieties of thrombophilias that can really affect. But ultimately, the rate limiting step is the inadequate amount of blood flow that is coming to the uterus. So meaning thereby uterine arteries की जो flows है वो कम है. और as the baby is growing, this is first and second and third trimester में, so the growth of the baby is exponential. Meaning thereby that if it is 1 in first trimester, it would be 3 in the second trimester, it would be 9 in third trimester. So exponentially the baby is growing. The growth of the demand from the baby is also growing exponentially. Usually by the late second and early third trimester, we would have this dwindling of the uteroplacental insufficiency. So the mother can have a PIH or preeclampsia, or probably we are just at the cusp of like we just so proteinuria is 1 plus but less than 2%, less than 2, or the diastolic blood flow in the mother is touching 87 88 but less than 90. But on an ultrasound what we can see is this, that the umbilical artery flows are absolutely increasing, like that had happened in the first case. So and so the absent end diastolic flow had started to appear, there was a starting for the PIH and preeclampsia, the amniotic fluid started to decrease, and there was a growth stagnation, meaning thereby that we identified that this the growth of the baby is showing an S-shaped curve. So meaning thereby that the element of the disc maturity started to set in. So meaning thereby that if we would have waited for 10 more days or 11 more days, then probably any appreciable increase in the birth weight was sort of an would have been negligible, right? But in the second case, what happened is this, that she was very well into our follow-up, and then we also identified that the uterine arteries are increasing, but then she was on a low molecular weight heparin. So as soon as we identified that there was something going wrong, and then the uterine arteries are with the resistance and the pulsatility index, the RI and PI of both the uterine arteries are greater than 95th centile. So we increase the doses. So and similarly, the beneficial effect was this, that with the if you can go back and look around, right uterine artery was following this chart, but appreciably when we increase the dose, the left uterine artery decreased down the resistance had fallen, and then it has crossed the 95th centile, and then it had come below 95th centile, right? So meaning there was that there was an appreciable amount of flow that was coming, that was not coming earlier, but now what we identified that the blood flow from the left uterine artery also helped to decrease the resistance in the umbilical artery, vis-a-vis increasing in the amniotic fluid index, and then there was an uptick in the abdominal circumference. So there was a catch up in the growth of the baby, and that was reflected into the fetal weight, right? So the crux is this, that probably this Clexane or a low molecular weight heparin can really help tide over this time of crisis, meaning thereby that from 28 weeks onwards, which we identify that the baby is something around 1100 grams to something around 34 weeks, when the baby is sort of mature, the lungs are also mature, and then there is a total pulmonary maturity and the fetal maturity is there, and the birth weight is also something around 1.8 kgs. So meaning thereby that from 28 weeks, which is for sure it is an NICU admission, to 34 weeks, it would become a take-home baby, right? So the titration of the low molecular weight heparin vis-a-vis with the umbilical artery Dopplers and the uterine artery Dopplers and the fetal medicine opinion, who can really titer these doses out, and then we can help and salvage these babies, gaining some more weight, gaining some more gestational age in the mother's uterus. It is not something that probably we are telling them that the pregnancy would go up to 38 weeks or 36 weeks, but probably salvaging those pregnancies from delivering a prematurity or preterm low birth weight babies to something around a take home baby at something of 1.8 and 2 kg babies, which I believe would not need an eco admission, right? So this is how the titration of the doses of the low molecular weight heparin, which is a Clexane, on gradual basis every, and then we titrate those doses depending upon how the uterine arteries and the umbilical arteries are behaving, and if they, even though we identify that the Clexane would work in only 70% of the cases, not all 100% of the people or the patients, they are going to respond to this low molecular weight heparin, but eventually it is very good seen that probably an ecospirin and low molecular weight heparin would work in two-thirds of the cases, and we can definitely add on to the birth weight and to the gestational age to the fetus by titrating the doses of the low molecular weight heparin vis-a-vis with the umbilical artery and the uterine artery flows, right? Thank you very much for your patience.